Hi, I'm Patrick Kotnick, and I'm the Marketing and PR Coordinator here at EveryLife Foundation. September is Newborn Screening Awareness Month, and if you're like me and don't know a ton about newborn screening, then you won't want to miss my conversation with Annie Kennedy, who's the Chief of Policy, Advocacy, and Patient Engagement at EveryLife Foundation for Rare Diseases. In this conversation, Annie breaks down newborn screening, RUSP alignment legislation, current legislation, how it all works, and ways that you can get involved. We thank you for listening and for watching. Be sure to subscribe to our YouTube channel for more content, and thanks for tuning in. My name is Patrick Kotnick, and I'm a patent advocate for a cure. So just to start off, in a nutshell, it's kind of a loaded question, but in a nutshell, what is newborn screening?
In the US, every baby who's born in the US in a birthing center or in a US hospital receives a screening for conditions that can be treated at birth that have been approved by the Secretary of Health and Human Services as having a public health reason to screen for them, meaning that the benefit of screening for those conditions outweighs the risk of conducting the screen. And so for the majority of those conditions that we screen for, if you have a baby here in the US, your baby has a heel prick done within the first usually 24 hours of birth, which is just a simple little prick on their heel, and a blood spot is taken from their heel. And we screen for a universal panel of conditions. And then the additional screenings that are done is that there is a congenital heart screen that is done to detect for congenital heart conditions, and that there's a hearing screen that's done that's screening for hearing loss in the United States. So that's the concept of newborn screening. What happens in the US, though, is that there is a federal panel where the Secretary of Health and Human Services has signed off on federal conditions, but that panel is referred to as the Recommended Uniform Screening Panel, with the emphasis on the term recommended. So those are conditions that are federally recommended for screening, and those recommendations then go to the states, and then states have their own panels that make the determinations for which conditions are then screened for at the state level. What happens is that there's a lot of variability from state to state as to which conditions are screened for at the state level. In states, those states can choose from that federal panel. So they can say, from this federal panel are now 36 conditions, we may be screening for all of them. We may screen for some of them. And then in many states, they screen for some additional conditions that are not on that national panel yet. But we have in the US some states that screen for as few as 31 conditions, and some states that screen for as many as 60 conditions. So there's a lot of variability in the US for what your newborn is screened for, depending on the state in which your baby is born.
So why is that? So there's a federal list, and I don't I know some about newborn screening, but not a lot. And I've kind of joked, but I'm also serious that when I say, like, if you can get me to understand it, then we can definitely get anyone
Yeah.
else.
Mm-hmm.
But
Yeah.
why is there like a federal screening panel, but then it's up to the states to decide to decide which ones they get to screen for?
Yeah.
The federal panel.
I mean, basically, states have the authority to determine their states' rights, right? States have the authority to govern for themselves on many issues, this being one of them. But the real issue around why there's such discrepancy between the federal panel and the state panels, so I think the bigger issue is, why don't states automatically screen for all the conditions that are on the federal panel? So maybe I'll back it up even and say, what's this federal panel even about? And so for a condition to even make it to this federal recommended panel, there's a very heavy lift on the part of the groups that do the nominating. And so for a condition to be nominated, communities, and usually it's patient groups, have to develop the evidence that determines that a condition can be screened for, so that we have a valid, reliable screen for the condition that can be screened for during the newborn period, that the screen is super inexpensive. And when I say super inexpensive, I was a part of a patient community that has worked for many decades to develop a screening test. I was a part of the Duchenne community and helped lead the Duchenne newborn screening efforts. And in our eyes, the first screen that we developed for Duchenne was incredibly inexpensive, especially compared to how much it costs to do testing for Duchenne ordinarily. And so our first screen that we developed for Duchenne was about $1. And when you think as a member of the patient community how much diagnostic testing typically costs, $1 seems like nothing. But from a public health standard, $1 is a lot of money when you think about adding it to a federal screen, that you will be screening all babies and all newborns who are born in the US in a year. $1 is too much to consider adding that to a federal panel. So the cost for that has to still come down. So they look at the cost of the screen, they look at the cost of adding it to what's currently being screened for, and then they look at the risk of having false results presented to families, because what you don't want to do is falsely notify a family that their baby might be at risk for a condition too often. And so the other thing that they really look for is evidence that if we detect this condition, that we can do something about it in a timely way, and that this is a condition that would disrupt normal childhood development. So those are some of the criteria that are considered by the Evidence Review Committee that the Secretary of Human Health has developed. All of that evidence that's necessary, the rocks in that backpack that I often refer to, often fall into the arms of patient advocacy organizations. And that's a lot of work to conduct those pilots, to develop those screening tests, to get those screening tests validated, to develop those materials that patients and providers use in education, and then those follow-up networks. But even once all of that's done and all of that evidence then goes to the Evidence Review Committee, and then if the Evidence Review Committee deems that this is a condition that we can screen for, and we can do it outside of a controlled pilot, but then nationwide, then that recommendation goes to the Secretary of Human Health, and the Secretary signs off on it. That's when it becomes a recommendation that states can consider. The next layer, though, to your question, is then states have to think about, do we have capacity to do this in our state? Do we have the technology to add this screen in our state? Do we have the providers that once we've identified this baby can then treat this baby quickly in our state? Do we have the networks to establish and safely and comprehensively care for this family? So while it sounds at first glance, well, why isn't everybody doing it? It really is everybody's sort of thinking about, we have to be responsible about this. We also have to make sure that this is funded, and we have to make sure that the turnaround times are going to be quick. We can't alert a family that they have a child that may have a life-threatening or life-altering condition and not immediately be able to send them someplace where there will be care available. So we have to have those networks tightened up. And what that might look like in a major metropolitan area might be very different than what that looks like in a rural community. But we have to make sure we have the same standard for everybody. So those are some of the reasons why you see discrepancies. And when you think about a public health program, we have to solve for all of it.
So on that note, so is it, when it comes to like conditions and diseases, are like the ones that are really going to be considered are the ones that have kind of treatments and cures? Because so for like Batten disease, 13 types, only one type has any kind of FDA approved treatment, which is CLN2. So above the 13 types, would CLN2 have like would that be the only one that had a chance to even get on there?
So this is where, just for clarification, I am not on the advisory committee for heritable disorders. I am a patient advocate, and I like to tell people I'm passionate about advocacy. One of the evidentiary criteria is that there has to be an intervention that warrants alerting a family and adding a condition. There's a lot of gray area about what that term intervention means. So to some on the advisory committee, intervention might mean FDA approved therapy. And oftentimes it seems that that might be the default. But intervention to a lot of us might mean that not having to go through a long diagnostic odyssey and have irreversible disease progression occur would be a reason to have earlier information. And interventions in many disorders can also mean physical therapy, early child services, preventing developmental milestones from being lost. There are other types of interventions outside of FDA-approved therapies. So one of the things that we work on at the EveryLife Foundation is working with communities on seeking what other evidence communities may be able to bring forward to the advisory committee that if you do have a condition that has an FDA-approved therapy, great. But that may not be the only reason to screen for a condition, as we all know. There are lots of other reasons that many of us in the patient community feel like it would be important to be able to screen for conditions earlier and actually stop the cascade of the disease progression sooner in other ways, even absent an FDA-approved intervention, and while we're trying to develop FDA-approved interventions. So that could be a whole other conversation for a whole other time, but we really take exception to the fact that there has to be an FDA-approved therapy. I will say, though, one thing you flagged there is in many of our diseases in the rare disease space, there are subpopulations. So as you just said in Batten, there are subpopulations within our diseases. And the committee is very specific about making sure that we can detect for specific disorders within conditions, because we want to make sure if you have a condition, if there are differences within conditions and one is early onset and one is late onset, we need to be responsible about who we're notifying and who we're detecting. Batten is probably not that example, but there are diseases in which you may have a form of the disease on the same gene that the onset would be in childhood and that would shorten life expectancy. But on the same gene, you have a form of that disease where you may not even have clinical symptoms until you're an adult. And so a lot of communities are really working to develop screening tests that are sensitive enough that you wouldn't necessarily identify somebody whose first symptoms would be at age 30 rather than somebody whose first symptoms would be at age 4. And so we do have to make sure that we're being responsible as we're thinking about newborn screening in the general population.
Going back to just information about newborn screening in general, I mean, what are like critical facts that, like, say no one knows anything about newborn screening up front, like what would be some of the most critical things that, if they take away nothing else, that they should take away these things?
Yeah. I mean, the first thing is to know that this is a public health program. Newborn screening is believed to be one of our nation's most successful public health programs, and it works. And we know that newborn screening does save the lives and change the outcomes for our nation's newborns. We also feel really strongly, though, that we have already added the conditions that we consider to be low-hanging fruit to the newborn screening panel. And right now, I think we're making it harder and harder for new conditions to get added. And there are so many other conditions that are worthy of being added that we know we have developing or developed FDA-approved treatments for, or we have interventions that could change outcomes for patients that need to be introduced earlier than we're currently identifying patients. And we need to figure out how to be detecting those conditions earlier. And we need to do a better job of lowering that threshold for adding conditions to the newborn screening panel so that we can be making sure that more families are equipped with knowledge about their child's condition and not sent on this years-long diagnostic odyssey and losing valuable time when they could be optimizing the care and health of their child. And so while we have a program that does function and work, we have a program that needs to be modernized and enhanced. given the opportunities and innovation that we have today. So that would be a really important thing. The other thing is that if you know nothing about newborn screening, and this is the first time you're learning about it right now, it is important to know that states differ in what's being screened for. And you can go to, we have a newborn screening action center on our website at everylife.org. And you can scroll into our newborn screening action center and look state to state to see how many conditions are screened for in your state and what's screened for, and get a sense of how many conditions are screened for and what's missing from the federal panel versus what's available in the federal panel. And that would really help you understand where your state sits in all of this. And there are really important action items that you can take, that if you have a state that is lagging in the adoption of conditions that are added to the RUSP, EveryLife leads with the community legislation that's called RUSP alignment legislation, where we work with states to add bills to the state level that require that states add all conditions that are on the federal RUSP within a 2 or 3 year timeline. But because what we don't want to have happen is that once we've gone through all the steps to make sure that the Secretary of Health and Human Services and the Evidence Review Committee say this condition must be screened for, we don't want it to take 10 years for one state to start adopting it, which has happened before, because it should not take 10 years for children who are born in a given state to benefit from what a federal advisory committee says needs to happen. And so that's work that we are doing, and we're looking for advocates to help us close those gaps.
So you mentioned having like the low-hanging like fruit when it comes to conditions added to the RUSP and stuff. But what are some of like the common hurdles that come with trying to add more conditions to the RUSP?
Yeah, I mean, well, first of all, you have to have a pilot to a newborn screening pilot to develop evidence to show that you have a screen that can detect conditions in the newborn period, that you can do so without having false positives or false negatives, meaning that you identify families inaccurately during that newborn screen time. So you have to show that you're doing this accurately and that you're doing it at what's considered to be a low cost to the public health system. You have to be able to set up, very importantly, a follow-up infrastructure. So materials that are both patient-facing, so materials for the families who would be identified, and the providers, because as we all know, we're talking about rare diseases. So your typical pediatrician probably hasn't run across Batten very often. And so very likely the person who is going to be treating that family in the newborn period has not encountered Batten disease or these conditions that we're talking about very often. And, I'm just thinking back to when my son was first born, I was really busy worrying about feeding and sleeping and, the things that you're really frantic about with a newborn. And now you're layering in one more level of really significant information. And so what we have to do is take a lot of the materials that as patient advocacy groups that we already have, but modify them and think about them through the lens of now parents of newborns. And so patient groups spend a lot of time doing that and modifying their resources and their websites so that if you have a new entry point for families who are coming in at the newborn period, what does that look like? And what kinds of information do you need pediatric providers to have? The other thing is we work with clinicians to do the same. So who are your clinical experts in the community, and what will they be now doing for newborns? What will the follow-up periods look like? Will they be the same as you have when children are clinically symptomatic and being diagnosed at that time period, or will they be different for newborns? So a lot of that work is done, and sometimes it's done with your clinical experts in your patient community. Sometimes that's done with the American Academy of Pediatrics, but that's a lot of the work that patients groups do on the front end to make sure that we have those follow-up networks in place. And then early intervention services become so important at that point, as you well know, and working with those partners and providers to make sure that, again, we're going to have those services in place for families and just, again, make it sort of a smooth on-ramp for families to understand where the opportunities are, where the resources for them are. once their child is diagnosed. And if there are clinical trials, if there are new therapies, what those options are for families as well. So those are sort of the packages that and services that we work to wrap around families and have ready, and then bring to the advisory committee. We also need to understand, is there data? Can we better understand what the difference between the health outcomes of children who are diagnosed at the newborn period are versus children who are diagnosed later? That's some of the data that the advisory committee looks at. Why would we need to diagnose people earlier? Does it matter? And collecting that data is actually much harder than it seems, especially when you don't have a population yet that's commonly being diagnosed as newborns. So if you have data around siblings, if there are siblings who are being diagnosed earlier, collecting that data in sibling studies becomes really important for our communities as well. So that was quite a list. I just rambled off to you. But again, that's why to do this work often falls to patient communities, because we're the ones that are really the experts around the diseases that we're working to nominate, and know where all of these resources are and live, and also know what types of services would need to be wrapped around a family and how to really enhance them and modify them for those who would enter in the newborn period.
So generally what everything you just described there, I mean, that's like the process, like for example, like if if like the community wanted to like made it its goal to add like CLN2 to try to get CLN2 to the RUSP, everything you just listed off there, is that generally the process that they would have to go through?
Yes, absolutely. And we offer what we call the newborn screening boot camp. So we offer resources and tools for families that are looking to do this work, and almost like a concierge type of service to help work with communities that are working to develop nominations and do the work as well. And so all of that is available on our website as well. And then our next boot camp is going to be held on October 31st is the evening before, and November 1st is the actual meeting itself. So anyone who's interested, or somebody from the community is interested in leading lists, we'd be happy to speak with you and really help you along the way. Because again, we don't want to see any community have to reinvent the wheel on this. And there are so many who've been doing this work already. And so to connect you to others who've led nominations or in the process of leading pilots, so that we can really learn from one another as we do this work.
You had said earlier about how you tend to focus on, diseases and conditions that have a treatment. You tend to focus on something like that. And I think you explained it, but can you explain that one more time, please?
Yeah, so one of the evidentiary requirements of the Advisory Committee for Heritable Disorders in Newborns and Children, which is the federal committee that reviews the nominations for conditions that would be added to the recommended uniform screening panel, is that there's a reason to identify babies early. Is there an intervention that would be offered to families if they were identified as having a life-altering or life-threatening condition that would be identified in the newborn period? And so there's a lot of gray area, though, around what the term intervention might mean. It's often interpreted as being an FDA-approved therapy, but that doesn't necessarily have to be. So there are times when in a condition, the intervention that could really change a health outcome might be early intervention services, or it could be physical or occupational therapy, or it could be nutritional therapy. So that intervention is gray, that definition, and really could be determined by the data that's collected by the patient community. The real question is, can we as a patient community show that identifying children earlier in the newborn period versus after a diagnostic odyssey and clinical symptoms have shown makes a difference? And what is that intervention that consistently can be offered that changes that outcome?
When it comes to just advocacy in general for newborn screening and RUSP alignment legislation, I mean, have you seen the advocacy in these areas evolve at all? Like, how have they evolved, and what are just some of the common, advocacy, I guess like the common advocacy, that you're seeing, that you're participating in today, and the common issues surrounding RUSP alignment and newborn screening?
Yeah, most definitely. I mean, I think the patient community has always been incredibly savvy in this realm as far as advocating for conditions to be added to the recommended uniform screening panel, but we certainly have seen this space evolve with, you know, I would say probably the majority of conditions that have been added since the first core panel was established have been added because patient communities have galvanized to develop the evidence required, have funded very sophisticated pilot studies, and helped drive and lead those studies, and then have led the nominations for the conditions that have been added to the RUSP. And we certainly don't do it alone, but we do have to find those clinical experts and then those newborn screening experts and bring them together to be interested in our spaces and to really develop the momentum for the newborn screening programs in our space. So, for example, I'll use Duchenne as the example because that's a space that I've worked in for a very long time. We have conducted multiple pilots on the state level in Duchenne in Ohio and New York. We had to raise the funds for those pilots and get the state labs interested in working with us, and then work to design what those pilots would look like. And those pilots are conducted in hospitals in the states. So then you also had to figure out which hospitals and which labs you would be working in. Because remember, what that means is that in birthing centers and hospitals, there will be people in those hospitals who will consent families. So these are opt-in consent pilots, meaning that somebody will go and meet with a family who is having a baby and say, in addition to the conditions that your child will automatically be screened for, there is a pilot being conducted to also screen for the following condition. Do you give permission for your child to be screened for that condition? The pilots that we as patient groups fund pay for that person, that consenter, and for that process, and then fund that additional screen to be conducted. So that when we say we're paying for a pilot, we're paying for that person, we're paying for the principal investigator in the hospital who's a clinician to help lead all of that work. You're paying for the lab in the hospital to do the blood stick and the draw. You're paying for it to be sent to the laboratory in the state health department, and then the collection of all of that data. So it's quite a sophisticated process that patient groups are helping to lead and coordinate. And it's also very expensive. Then all of that data gets brought together, and that's what gets brought in front of the recommended uniform or the advisory committee for nomination to the recommended uniform screening panel. They also then look at the follow-up that happened. So when families were consented, how did that process go? If a family was identified as having a positive screen, so if it hit the level above what was considered normal, how long did it take for them to be notified? And was that test reconducted? Did you confirm it again? And then did you send out for the genetic test after that? And how long did that take before results were delivered? And then how long did it take for them to be referred to a pediatrician and a specialist? So that whole process is a part of the pilot that you put together. And then the timeline for referral is also something that's analyzed and watched. And we really work to tighten those timelines up as much as possible. And so that's what you're piloting. And a pilot is what would then become a nationwide referral program for your condition.
So I guess now, where do you recommend, like, doesn't have to just be the bat community, but just, rare disease, bat community, like where can where can they start? I mean, like if they don't know anything, I know you kind of you gave the rundown of facts that they should know right away. But where's a good starting point right now for if people want to get involved?
Yeah. So the first thing I would do is I would go to the EveryLife Foundation website and go to our Newborn Screening Action Center. And there's a lot of terrific information there about what newborn screening is. There is a lot of great information on our newborn screening boot camp, which has a lot of basics. It also has previous presentations from previous newborn screening boot camps from leaders in the newborn screening space, and some of those who lead actually the advisory committee and help lead the evidence review process. So their perspectives on the evidence review and the decisions that the advisory committee makes. And so we have sort of 101 level and 201 level introductions to the process, what's required in the evidence review, what goes into a pilot. So all of that is really laid out there. We also have publications from patient groups that have done this work before and then published their methods and some best practices. So that's all linked on there. So we really work to sort of pull anything that groups are doing into that as sort of a one-stop shop for other communities. And then again, there's information about our upcoming boot camp that will be on November 1st. It is in person in Rockville, Maryland, but it will be streamed. So if you can't come to Rockville and you want to watch it that day, you can also stream the boot camp, and registration is currently live to participate in that. So if you just want to learn more and listen in and hear about what's happening and how to think about the process and also what's changing, because this is an ever-evolving space, we would love to have you participate. There is no cost to participate in our boot camp.
And is there any current legislation, whether it's federal, local, state level, that is currently in the works or that people can help advocate for now?
Yes, this is my favorite topic. So the federal bill, the federal legislation that authorizes the newborn screening system was not successful in the last Congress. And so the authorizing language to keep all of these wheels moving has actually lapsed. And so we are actually right now in the process of starting the drafting and crafting of new legislation. So this is a really important time for the community to really be engaging with us on what our priorities are. Just yesterday, we actually published a report, and I encourage you to share it and drop a link with this video on opportunities to modernize our existing newborn screening system. Last year, we conducted a series of roundtable meetings with the broader patient community and some of the world's top newborn screening experts, and collected ideas from across the ecosystem. And the report that we put out yesterday pulls all of that together into the top line policy suggestions that came out of that series. And now we'll be taking what we put out in the report yesterday and moving into operationalizing that into actionable policy ideas for federal legislation. So that's the federal piece. On the state level, we lead efforts to make sure that conditions that are added to the federal panel can swiftly move into states. So as I mentioned, because of the distinction between the federal recommendations and then the ability for states to then have to make decisions on a state level, there can be a lag from anywhere from 3 to sometimes 10 years before a condition that's added to the federal panel gets added to a state panel. What that means is that there can be life-saving therapies approved that the babies are not being screened for in a state, and that's not acceptable to us. So we lead what's called the state RUSP alignment legislation, where we work with states to pass legislation in individual states that creates a funding stream for states, that eliminates a barrier for state administration, and a timeline so that conditions that have been added to the RUSP can be swiftly implemented in states. We've currently passed that legislation in 11 states. We're still working this year in Wisconsin, and next year we'll be working in additional states. So we encourage folks to, again, go to our Newborn Screening Action Center, look at where that legislation is already passed and where we're currently working and where we're getting ready to move to. Our goal, so currently right now, more than 48% of babies born in the US are born into RUSP-aligned states, which we're thrilled about. Our goal is that by the end of next year, we're at the 60% tipping threshold. So we really need the patient community to work with us, especially if you have connections and state legislators or are just boots on the ground in some of the states where we're not yet RUSP-aligned. Our patient advocacy community are the ones who've really helped us get this done. So absolutely, there are action items to take both on the federal and the state level.
Any other like specific action items that you can think of outside of that?
I mean, I think education is key. We will actually be releasing a report next week around the diagnostic odyssey in rare disease and the cost of that diagnostic odyssey. As you may know, we did an economic impact study that we released in 2022 around what the economic impact of rare disease more broadly is. And one of the findings of that study, because there was a survey that the community was very generous in participating in, one of the findings from that is that the diagnostic odyssey, of those who participated in the survey, was an average of over 6 years and included 17 providers. So we followed that thread from that survey and have conducted a health economic study looking at the cost of the diagnostic odyssey. Can we really start to put some numbers to how much that's costing us to have that really expansive diagnostic odyssey? Again, to really underscore the importance of newborn screening and other diagnostic technologies. And we'll be releasing the findings of that next week. And we chose 7 diseases to do the study because we couldn't look at the whole universe of rare disease to do this particular study. But the study's not just about those 7 diseases. It's about all rare diseases and the need to eliminate avoidable costs because we have the technology to do better. And no family should be on an unnecessary diagnostic odyssey and paying out-of-pocket costs and even having the direct costs in their healthcare system spent when we could completely eliminate that cost through a very inexpensive newborn screen. And so when those results come out next week, we would really appreciate the community really wrapping your arms around that and then telling your own story around your diagnostic odyssey, personalizing that data. Because for us, it's not about data, it's about the journeys that that data connects to. What does that mean to you? What do those costs mean to you and your family? When we say outpatient costs, what does an outpatient visit mean to your family? Because I think in the main community, people think, oh, outpatient visit, I go across the street to my doctor. Well, we all know in rare disease, our doctor isn't usually across the street. So what does an outpatient visit entail? What does an ICU stay actually entail? So putting really a face to the data we're getting to put out will really help us optimize our messaging and drive the policy impact that we can have when we say we have the technology to add more conditions to the RUSP. We have the technology to eliminate the diagnostic odyssey in more of our communities, for more of our communities, and we have to do better.
Yeah, that's for sure. Have to do better, and that's lots of great information, and I really do appreciate you again taking the time to do this. Just one more time. I know you've already kind of you've already gone over it a couple of times, and I hate to make you repeat yourself, but just summarize one more time again. Just if anyone like if the community wanted to get any of the types of Batten disease on the RUSP, what's just kind of like sum her up as brief as you can, just kind of like the steps that would go towards achieving that.
Yeah. So if you're focused on getting any type of Batten onto the RUSP, one of the first things you need to do is galvanize as a community and find patient experts, clinical experts in Batten, and some newborn screening experts and bring them together and really identify where you are in Batten as far as newborn screening. Do you have a valid, reliable screen for Batten? And is that valid and reliable through the eyes of a public health laboratory, which is different than whether if you were coming into a clinic as a clinically symptomatic patient. So that's one of the first things that you need to do. The next thing is you really need to think about what follow-up would look like. What are the materials that patients receive? What are the materials that pediatric providers would receive? What are the materials that specialists receive? And how do those need to look different if you're talking about somebody who's being diagnosed in the newborn period versus somebody who's being diagnosed later? What are the clinical care guidelines? Do you have recommendations in clinical care guidelines for newborns? Do you know enough yet to make those recommendations? And if not, what do you need to fill those gaps, and how do you start to get there? What is an intervention for a newborn, and why would you need to intervene? Are there FDA-approved therapies? Are there early intervention services? Are there developmental milestones that would be missed or gone undetected if you're not diagnosing earlier? What health outcomes are you going to be able to optimize because you're diagnosing earlier, and then work backwards from that to start to make the case for the need for newborn screening? And you're going to need data to show that you can optimize outcomes, or there is a reason to be identifying newborns earlier. It may make perfect sense to us. It may just seem like the ethical thing to do. But when you talk about evidence, you're going to have to show how and why you're optimizing those outcomes. So how are you collecting that data, and where is the data? And that's what takes a while to do. That's sort of the challenge in newborn screening. So those would be the first things that we would recommend that you start doing. And again, you don't have to do it on your own. There are a lot of partners and communities out there that are really eager to work with you to support that. And the first place I would start in sort of navigating and getting your footing is at the EveryLife Foundation on our Newborn Screening Action Center, to sort of get a sense of what other communities have done before and who some of those communities are. And then we're happy to put you in touch with them.
Annie, again, I can't thank you enough for providing all this great information. Is there anything else that you want to add that maybe I didn't cover?
No, the last thing I would just say is that I have found that the newborn screening community and those within the rare disease community who work within the newborn screening community are far and away some of the most generous people that I've ever encountered, because we all have the same shared goal of really taking care of one another and optimizing the health outcomes of our children. And so I would just not hesitate, if you're listening to this webinar or video, if you're a part of this community, there is no silly question. There is no thing that you should have known before. Please reach out. Please do not hesitate to ask questions. Listen into the meetings. If you're not available all day on November 1st, but you just want it on in the background streaming while you're doing other things, just begin to expose yourself to the language and the crazy acronyms that everybody uses. And there are so many, and just begin to get comfortable with the community and the people. Everybody would be happy to support you, welcome you, and acclimate you. We need to be able to identify babies as soon as possible, because we know that there will be and are better interventions that will only be able to optimize outcomes for those children the earlier we can identify them. And we're committed to working with you to do so.